Hello, everyone. Welcome back to our MEP pop-up learning session for EM and critical care medicine updates. We're glad that you're joining us again. We have many topics that we're going to cover with our expert panelists, and I'm going to hand over the mic to Dr. Manish Goyal, who's going to start us off talking about oxygenation and flow. So all yours, Manish.
Great, thanks, John, and hi, everyone. So we'll spend just a few minutes talking about flow and FiO2. This isn't something that we traditionally think a lot about in the pre-COVID era, but something that's really important to understand as we think about the different modalities that we use. So I want you to just start off by taking in a deep breath, and if you think about that inspiration and the flow that was generated as air moved into your body. And think about where in your breath the flow is at its highest. It tends to be highest at the beginning of the breath because that's where you have the highest pressure gradient between your intrathoracic pressure and atmosphere. And if we're to define how much flow that is, if we were just to kind of put this on this graph here, with the y-axis being your inspiratory flow and your x-axis being time, we'll say that it starts out, kind of up here. And as your breath proceeds, your flow drops and it comes back down to zero. Now, if you think about the area under this curve, that area represents your tidal volume. And currently, as all of us sit here and breathe, the FiO2 for that tidal volume is 21%. But what happens if you put somebody on 15 liters per minute of oxygen? What are they exposed to? You can kind of graph this out on our graph here, and you can see that there's 15 liters per minute of 100 oxygen constantly. So part of the breath that they get, and a good part of the breath that they get is 100% oxygen. And this is, again, in us who are breathing spontaneously and comfortably, where we may be generating, say, 30 liters per minute or so of peak inspiratory flow. The rest of the breath that we're receiving is 21% oxygen. So if we're to try to figure out what FiO2 we're receiving, it's going to be a mathematical average of these two spaces, and maybe we're getting 60, 70% FiO2. And again, that's considering us who are breathing now normally with a peak inspiratory flow of somewhere around 30 liters per minute. But what about our patients that come in really dyspneic? If we think about their flow, and you guys have all seen these patients, they're breathing a lot harder than they're breathing right now. They may be generating, say, 60 liters per minute of peak inspiratory flow. If we expose those folks to 15 liters per minute of oxygen via a non-breather, the proportion of gas that they receive, that's 100% oxygen, is substantially lower. Whereas the proportion of gas they receive, that's 21% oxygen, is substantially higher. So therefore, their FiO2 is much lower. Likewise, if you take some of these patients who are really dyspneic coming in, if they're breathing, say, 80 liters per minute as their peak flow, the proportion of gas that they receive on that same 15 liters per minute, that's 100% oxygen, is much lower. So in our sickest patients that are breathing the heaviest and the hardest, the FiO2 that they're receiving is the lowest. So what can you do about that? You can't give somebody more than 100% oxygen, but what you can do is increase their flow. And this is where we talk about exposing people to, say, flush rate non-rebreathers, where maybe we'll get up to 40 liters per minute. Significantly better, but there's still a fair amount of room air that patients are in training. On top of this, we can add nasal cannula. And so again, getting a higher proportion of that gas, that's 100% oxygen, but there's still gonna be a portion that's room air. And this is variable, really breath to breath variable. But this speaks to one of the advantages of high flow nasal cannula. With high flow, we can deliver with our setups up to 60 liters per minute of 100% oxygen. So again, by going up to high flow, we get a higher proportion of gas that's 100% oxygen that patients can get exposed to. If somebody's really working hard to breathe, they can still get some room air entrainment, and probably will get some room air entrainment. But this goes back to one of the differences between high flow nasal cannula and CPAP. And one of the reasons that I think CPAP is so beneficial in these patients. With CPAP, there's variable flow. So the device, when set up, can deliver a variable amount of flow, and you can control, the FiO2 of that gas. You can deliver 100% oxygen for essentially all of their flow. There may be some leak, there may be some room air entrainment, but you can get a substantially higher flow, and certainly higher than any other modality we have that's non-invasive. So I'll pause there.
That's great, Manish. And if you could start us off, and we have several topics that we want to cover during the next few minutes as a panel. And I see Janice has joined us as well. So welcome, Janice. We want to talk about community-acquired pneumonia. We want to talk about anticoagulation. We want to talk about steroids. We want to talk about optimal intubation and ventilation strategies and lessons learned. But let's start off with progressive oxygen delivery. And how do we incorporate these various adjuncts, and what have we learned thus far, and how has our strategy changed? When we first started with the pop-up sessions, we spent a lot of time talking about aerosol generation and some of the concerns with various modalities. We've really pivoted and adapted our thinking about that. So Manish, starting with you, and we'll go across the panel as well. What do you recommend when patients are coming in that are air hungry, not to the level where they need to be intubated, but what should our progressive strategy be in the ED setting?
Yeah, I mean, I'm interested to hear everybody's thoughts here, but what I do is I start them off on a relatively low level of oxygen, say 4 or 6 liters per minute, usually 6 liters via nasal cannula, and see what they do with it. There's a group of people who go from very low saturations to really coming up quite high, at least I think, and then progressively increase the amount of support that I'm giving them. And I try to, kind of decouple FiO2 flow and pressure. So I'm trying to deliver as high of a flow as I can of 100% oxygen. I should say I kind of target that flow first to try to get up to a peak sat before I introduce airway pressure. If with a non-rebreather plus minus nasal cannula, I'm getting enough support, then great. But then my next step is to go to high flow, unless the patient looks like they're really in distress and really persistently hypoxemic despite getting added a non-rebreather and nasal cannula, in which case I might go right to CPAP. And if I go right to CPAP, I'm usually using a CPAP of 5 or 8 with no pressure support initially, as long as their tidal volumes are reasonable.
So other thoughts from our panelists. Shane.
Yeah, I would say, I kind of agree with Manish's approach. I mean, typically, we've both been in the units for about 6 weeks now, and so typically we're seeing people that to make it to the units in this day and age, you're in a significant amount of extremis, and so we're usually seeing people starting at high flow and usually maxing out that therapy 60 liters 100%. And then sort of my next move after that is moving to some sort of non-invasive, often as a bridge to intubation or a bridge to improvement. And if you can get some improvement, then trying to step it back down to high flow nasal cannula, which I think is a more durable option for long-term care.
Great. Other thoughts, Rory and Janice?
I would echo their thoughts. A couple things. I usually, as Manish's diagrams show, that even on a high flow nasal cannula at 60 liters, if they're generating pretty high flow rates, you'll still start entraining room air, and so you're not going to get 100% FiO2. And so one of the nice kind of hacks that you can do is throw a non-rebreather over the top of it. And so then the air that they entrain is 100%, and that'll get you closer to 100% delivery of 100% FiO2. So I'll often do that on patients before going to non-invasive like Shane does. I think the interesting component from the emergency department, and Manish can attest to this, there is a group of patients that come in pretty bad distress that if you aggressively treat them with CPAP or non-invasive, you actually can titrate them down and get them off it. And what I think is happening is they've got this hypoxemia, which is generating these high flow rates that you no longer can keep up with. And if you can give them 100% FiO2 that can keep up with those high flow rates, you can then kind of decrease that sympathetic response, decrease their need for oxygen. They kind of slow their breathing down. And then now that their flow rates are much lower, it's much easier to control on lower FiO2 settings.
Great. Janice.
Hi. I have nothing really new to add, but it seems like people are either doing fine on high flow or high flow plus a non-rebreather. By the time we have them, just like Shane was saying, in the ICU, if they're not doing well on that, then I'm typically going to intubate them. I'm not using BiPAP as an in-between in that situation. We have not had good luck with BiPAP really at all. All of my BiPAP semi-trials have ended up intubated. I think it's a great idea in the ER if it's, the right situation, but I think by the time they're in the unit, there's, things have either worked or not.
Excellent. And turning it back over to you, Rory, let's talk about the optimal intubation and vent strategies and how they have evolved. And we started our very first pop-up, however many weeks ago that was now, almost 6-8 weeks ago, talking about optimal intubation strategies and our approach, and also talking about ventilation strategies. What have your observations been, and how has that thought process adapted and evolved based on our experience over the last several weeks?
I think the big thing is we're intubating them so much later now than we were earlier that I wouldn't pre-oxygenate them with anything other than a BiPAP circuit. I just don't think you get them to good levels prior to intubating them without it. And so almost instantaneously, I will switch them on to, if they're on high flow nasal cannula plus a non-rebreather, I'll take them off that and put them on a non-invasive circuit. Like Manish does, I usually find that 8 to 10 FP alone without any pressure support usually will actually oxygenate them, shooting for O2 sats as high as you can go, though typically at that point you're only getting up to 94, 95, 96, somewhere around there. Otherwise, I don't think much has changed. It's still a true RSI. They desaturate so quickly. You do have hypoxemic arrest during them, but a lot of them actually tolerate hypoxemia quite well. I think that's probably because they have some acclimatization to it because they've been hypoxemic for so long. And then once you get them on the event, they take a long time to come back up, meaning they will sat in the 60s, 70s, 80s for minutes to hours before you get them up to a sat that you're comfortable with. I think the important part there is, again, not to just empirically go up on your PEEP because we think that they're recruitable. A lot of them, especially early on, aren't. And so it's important to decouple that PEEP FiO2 ladder that we were previously recommending and rather use your driving pressure, which is essentially getting a plateau, subtracting your PEEP and figuring out what the lowest number you can get. So driving pressure is less than 14 are somewhat safe. And you'll see most of these patients, when you intubate them, their ideal PEEPs are somewhere around 8 to 12, somewhere in that area. And as you go up higher, you end up over distending them and creating more issues. I think the last issue that I find very frustrating with them is once the sedative wears off, they will go back to breathing 40, which is what they were breathing before you intubated them. And so it's not much of a surprise. A couple problems with that is because a lot of their compliance is somewhat normal, and you're usually using a volume mode, you're going to, every time they stimulate a breath, you're going to put whatever tidal volume you set, somewhere around 400 in. And because their compliance isn't so bad, I've seen a few of them breath stack on you, which is kind of unheard of in ARDS otherwise. And so controlling their rate is really, really important. And they require large doses of opiates to do so. The way I do it is I use ketamine and fentanyl in the ED. I find when you use propofol and start cranking it up, they start getting hypotensive. You turn it down, they start breathing fast again. You turn it up, they get hypotensive, and you go back and forth and never get them comfortable. So I usually use ketamine and then use high doses of fentanyl on 200, 250, somewhere there to really suppress their respiratory rate. And if all else fails and they really are breath stacking despite that, I will paralyze them until I can get them under control.
John, if I can ask a question about that.
Yeah.
Rory, are you using bolus ketamine one time, or are you doing multi-dose? Because I use ketamine.
I think it's easier to bolus it as many times as you need intermittently. Okay. And then with the fentanyl, eventually you can get them quite comfortable on propofol and fentanyl. It's just it takes a little while to find that happy medium.
It's a great question. And Janice?
So we've luckily not been having too much trouble during the actual intubations. We've usually just been throwing a non-rebreather on and just cranking it up as high as we can go. We have a pretty set now, put everyone on either 8 or 10 of PEEP, leave them on 100% FiO2, and then kind of deal with things based on how they look after the whole intubation process. Our kind of set plan with intubation is we RSI them, and then almost everyone gets a dose of rock right after, and then we put central lines in all of them, of course, art lines in everyone. We assume everyone's going to get hypotensive, and then we put everyone on propofol, fentanyl drips, usually Precedex as well. If their triglycerides go up, we take the propofol off, put them on a ketamine drip, and that's been working well. But they, it's a ton of sedation, and on the back end, we're so lucky. We have a really great palliative care pharmacist who's been helping us with the withdrawal, like a withdrawal regimen, because we put everyone into opiate and benzo withdrawal in the end, if we get lucky enough to get them through their respiratory failure.
Great. And turning it back to Shane, wanted to talk a little bit about anticoagulation. There's been a lot of discussion, a lot of literature that's evolving and emerging in this domain, a lot of experience from all of us that are working either in the ED setting or in the case of many of our expert panelists here working in the critical care unit. What are the latest thoughts, and what should we be doing in terms of anticoagulation for these patients from ED perspective, from a hospitalist perspective, and ultimately in the ICU for our sickest patients?
Yeah, I mean, so I think that for most people who have taken care of these patients, there's sort of becoming there's no denying that there's a hypercoagulable component to this disease. And there's a lot of evidence in the sort of early literature that shows that there's sort of macro and micro thrombi. And anecdotally, I've seen multiple macro thrombi, multiple people with pulmonary embolism, VTE, and so most major centers have moved towards some sort of anticoagulation protocol for these patients, and MedStar has as well. And there's actually a document that sort of lays out the anticoagulation protocol available through Starport on the COVID resources. If you look at that document, I would say we have a more conservative protocol. I mean, some institutions are putting all these sort of critically ill patients, so anyone requiring supplemental oxygen, on heparin drips. And then, some are sort of doing a more tiered approach. I think we're a little bit more of a tiered approach. The average risk is the sort of the lowest category, which they're just getting prophylaxis dosing, which is, it's kind of typically what we do. And then, of course, the really high risk, or the ones that you really think clinically might have VTE or a PE of some sort, then they're getting sort of the full anticoagulation, which I really don't think is much of a practice change for anyone. So the real,
I think
and that's putting together sort of a lab component and a clinical component that shows that people are hypercoagulable, whether you're looking at your fibrinogen, your D-dimers, your clinical picture in general. I mean, I've had multiple people where you're putting a line into the patient and, a trialysis line literally clots on you, which I've never really seen before in my life. Normally it's just that thing's flowing. And so, and also with CRT machines, I'm just seeing levels of clotting I've never ever seen before on CRT, no matter what you do with sort of your dose adjustment. So in those patients, which I find the majority of the patients that I'm caring for typically fall in this intermediate, there's sort of this recommendation that we've had, which is doing enoxaparin, either 1 milligram per kilogram every 24 hours or 0.5 milligram per kilogram BID, or every 12 hours. On that, there was also the heparin infusion for the lower anti-10A goal of 0.1 to 0.3. I'll say my typical practice is to use the Lovenox 0.5 mg per kg BID. And I think where that's relevant to, practicing in the emergency department is I think there's little downside to giving that first dose of Lovenox early on, because if the team, the problem with this is that we, while we have a lot of data that says, there's a signal to this, obviously the data is not as robust as we'd love. These are not RCTs. Just by the nature of this disease and how fast it's moving, we're not going to have those. The most recent thing was a JACC article that was looked at Mount Sinai's experience and showed a significant reduction in mortality in those that received anticoagulation. It wasn't the best study. Like, it's not something that I'd hold up and say this is how studies should be performed. But again, in the circumstances, this is the data we're going to have. And so I think there's a little downside in doing that first dose, and it really is going to require sort of clinical decision making for this for every individual patient. But I think you give them that first dose, and if the sort of team decides for whatever reason we're not going to go forward with this, at the very minimum they've gotten their sort of prophylaxis dosing. And if the team decides to go forward with it, they can add on the second dose and put them on that regimen if that's what they think is best. So that's my thing. The other question that invariably comes up is about D-dimers, and I don't know what to do with them. So I treat D-dimers like I've always treated them. They're a mythical creature, and they cause a lot of angst. And sometimes I ignore them. Sometimes I pay attention to them. Sometimes I use them when I want to use them. So I don't know what to tell you. Most of the people we see in the ICU with that either. I don't know if anybody else has opinions on this, Roy, Janice, Manish.
I don't think the D-dimer helps at all making this decision. Again, I think the important thing to separate is the difference between treating or ruling out a macrothrombi and the role that the microthrombi play in this disease process, and whether using heparin to treat the microthrombi has any effect on the disease. And so the protocol that we wrote, and that is for MedStar, kind of encapsulates both. When you actually think the person has macrothrombi, that's when you treat them with full dose anticoagulation. This intermediate dose, which is essentially built for people who have the clinical syndrome that we see with COVID, which is high oxygen requirements, relatively intact compliance. So anyone basically who is being admitted to the ICU on escalating oxygen requirements, the thought is that this intermediate dose is intended to treat the microthrombi that may be contributing to the disease itself. Like Shane said, we don't have a lot of great data on it. I don't think the D-dimer is really helpful for me in making that decision. I mostly look at the clinical picture, and if they really look like they have COVID lung and are having up titrating oxygen requirements, is when I switch them to the double dose. And like Shane says, and like Manish does with his practice, if you give that first dose in the ED, that is essentially your standard prophylactic dose that anyone with COVID in the hospital will get. And the treating physician who's taking over can actually choose whether they do the second dose in the one day or they keep it to once a day.
That's great. And I think that's a very helpful frame of looking at it, the macrothrombi. And often that's what we're chasing in the ED setting, right? Is it does the patient in front of us, do we need to be worried about a pulmonary embolism, for instance, versus the microthrombi and its impact on various organ systems? So other thoughts, anything else to add to the anticoagulation discussion? Janice, Manish?
Hey, oh my God, I have so many thoughts. So I'll try to keep it simple, which is thank you guys for making the protocol. That was great. From my perspective, so I have this thing, right, where I'm trying to do something new every week because nothing's working, right? So every week I try to make a change in my practice to try to get something a little bit better. So I think we are way behind the 8 ball on anticoagulation. I think that that's the primary thing that's killing patients. I think that a lot of the other things that you'll hear, I really wonder how many rooms people have been in with these patients and felt them and touched them and seen what exactly is going on, at least from my perspective. I think thrombosis is a major, major driver of our mortalities. So I'm anticoagulating everyone. I'm not full dose anticoagulating everyone, but I want to. I'm probably going to start doing it as my doing something new every week thing on Monday. But we're we're anticoagulating everyone. I've switched some people this week over to argatroban. I've switched some over to fondaparinux because people have been clotting in front of me on full dose heparin drips. I gave someone a bolus of alteplase the other day just because I thought about giving someone following that kind of some of the new thoughts about giving 25 milligrams of alteplase over 2 hours, followed by 25 over 22 hours on people who are just clotting in front of you, like they're clotting their lines in front of you. So to summarize, I have no exact protocol. I'm somewhat following the MedStar protocol, but when you're looking at people clotting in front of you, they're clotting on heparin drips. They're clotting on everything. So I'm switching things around. I'll let you know if anything works the next time we talk.
And certainly important points that protocols and guidelines are the structure, that's the scaffold, but we need to always treat the patient sitting in front of us based on the clinical conditions that we're seeing. Manish, any comments from an ED perspective in terms of our workup and our evaluation of patients for conditions such as the macrothrombi when we're looking for pulmonary embolus?
Yeah, this is such an interesting question, and I agree with what everybody has said, but what I wonder about is if we should be dividing into micro and macro thrombi, right? If we think that the hypoxemia is related to microthrombi in the lung and the pulmonary capillaries, then why aren't we delivering full dose anticoagulation to everybody? I should say everybody that's sick enough to warrant going into an IMC or ICU. So if we quantify the degree of hypoxemia, and we say that hypoxemia, normal lung compliance, is probably more so related to microthrombi that we're not seeing, why aren't we anticoagulating these patients? And it's a bit of a rhetorical question in the sense that I don't know that anticoagulation makes it better. I think we all agree that thrombosis is a problem, but we don't know if anticoagulation helps that problem. But I think we should have an even lower threshold for full dose anticoagulation. And so, as I said, my own practice is 40 milligrams of Lovenox for anybody that gets admitted. But what I'm wondering is if anybody's going to the ICU, why not just anticoagulate them all at full dose? And maybe you guys are already doing that.
Not yet. So we kind of compromise when building the protocol. Hematology, balked at our initial idea to anticoagulate them all. So our intermediate dose was a compromise between the two. And to be fair, there is no data whether it actually helps, and like you said, whether actually treating the coagulopathy we're seeing makes a difference. But part of what happens in the ICU is you've got these really sick patients who end up being intubated, and everything starts falling apart. And often we say they might have a PE, we can't get them to a scanner, and so they go on full dose anticoagulation at that point anyway. I do wonder if you start them early enough when they're still on high flow, if you'll, where I think you get most of your win right before you intubate them, if you'd make a difference.
Well, that's exactly right. Because if you get to a point where your compliance is bad, let's say where it's way too late, right? You want to anticoagulate these folks while they have normal lung compliance, and the primary problem is the dead space from the microthrombi, I think. And so it maybe even speaks to higher levels of anticoagulation in those who haven't gotten that sick yet. But the challenge that we all want data, we're never going to have it. We're not going to have adequate data that are going to inform us on the practice. And
we will after this is all over.
Right. So we might for the fall and winter, maybe, but maybe not. I'm not convinced we're going to have a great RCT that's going to tell us the right thing to do.
So
yeah, I mean, I typically try and go through I think the problem with anticoagulation, right, is I am sort of with Janice and Manish, and I think we're all probably on the same page, which is there is something to higher levels of anticoagulation. The problem is I sort of look at this. Well, we'll talk about steroids, but so I have a different opinion about it, because I think the trouble with anticoagulation is there is more risk that comes with it than other things. And I think that's where you run into everyone has that sort of hesitation on the trigger. And so, and there's not any great data to support what you're doing. So it becomes a little more difficult in how to navigate that. And so what I've been trying to do is go up a ladder approach, just like we do for the, sort of what we talk about for the oxygen requirements is, try and put everyone on this intermediate dosing. I also wonder if there's a difference between, Lovenox and heparin from the sort of anti-inflammatory and the also sort of like viral binding sites. I don't know. I mean, there is some very basic research that looks at that stuff, but I don't know what to do with that in a clinical context. And then I try and move upwards as soon as I see sort of my first sign of like, macro thrombi, or clotting of CRT or that, then I move to the full thing. But your point is well taken. Is that sort of too late? But, all the ways we manage, but that's hard because how do you sort of marry those things together? And I'm sort of with Janice, every week I feel like I've lost again. And so I try and, bring some, new back to the game to see if I can, get something that makes a difference that moves it. And it's highly frustrating. It's very difficult. But I think the tricky part in this anticoagulation thing is that the risk that comes with it, and so that's what I struggle with on a daily basis is, you obviously want to do the right thing. You don't want to do any harm. And sorry, you're trying to thread that needle, which I find very difficult.
I totally agree with you. So 2 quick points. One, I would argue that I think that anticoagulation is the only intervention that we could potentially make that would actually make a difference. Everything else is supportive care. And the second, and John, this goes to your question earlier of what do we do different in ED? I think we swung too far from CTs and not CTing individuals. And so I heard my colleagues say there's little to no value to a D-dimer, which I understand. I wonder if there's value in it being a threshold to getting a CT. And my hope is we'll have more local data to help answer that question in the next 2 weeks.
And that's the last point I'd make on this is I have started to see just when you thought you had enough challenges, readmissions of people who were critically ill with COVID, who now have sort of some sequelae. And I just, again, anecdotally, I would be very, very highly suspicious of a patient who had COVID, who is coming in with any signs or symptoms of a PE. Because more often than not, I think that's what it is. And be very careful in trying to chalk this up to some sort of, COVID, related, actual COVID-related lung injury or ongoing infection. Every time I've seen that, they've been extensive PEs, which I think is going to be the new frontier of challenges in the next month or two, is going to be all these people that, we thought recovered, are in rehab, nursing homes, going home, and then coming back with their sequelae, renal failure, pulmonary embolus, VTE, et cetera, et cetera. So that's the only other thing is that was my latest experience last week, was seeing multiple of these patients initially COVID positive, in the beginning of the sort of the, initial surge of pandemic, now back with sequelae. So just be very, very suspicious of someone coming back.
Great points. Thank you. And certainly something that we're seeing in all age groups with all of the inflammatory sequelae that we're starting to see and is being reported more and more in children as well. And so that's going to be a topic of an upcoming panel discussion of pop-up learning. So switching a little bit to community-acquired pneumonia in the setting of COVID. So another easy topic to deal with, right? What do you do when you find infiltrates? Who do we treat? What do we use? Who do we admit? So I'll turn it over to Rory for thoughts about CAP treatment.
I think it goes broader than just CAP into when do you start thinking outside the box of COVID itself. And because, COVID, the disease process kind of spans from completely asymptomatic to dying in the ICU, you can have people presenting that are COVID positive and yet happen to have other disease processes. I say this a lot. I think Shane has actually said it too. The nice thing about COVID is all your labs could break and you could still probably manage the patient just as well because it's a very clinical disease and it's very clinically consistent. And so I often tell people that when the patient doesn't look like they're presenting like COVID, they might not have COVID. And the sense is these patients are extremely hypoxemic, but awake, they are tachypnic, though their actual work of breathing isn't as high as one might expect for their hypoxemia. They typically don't have a lactic acidosis. They typically aren't in shock. And so when they have these kind of high lactates or are in shock, I tend to kind of think you probably don't have COVID here and something else is going off. And quite often we find good old-fashioned sepsis or PE or something else that's kind of causing things, and the patient just happens to be COVID positive. The other day was an altered mental status who happened to have a brain bleed that also happened to be COVID positive. And the initial chalk up was like, this is COVID, but COVID shouldn't cause an encephalopathy until you're very far down the stream, and that's typically after you've already intubated them and snowed them with tons and tons of sedative agents. So for CAP specifically, I think it's a little bit trickier than standard COVID. Anytime they have a real work of breathing or I'm concerned and they look sick, I tend to cover them early on, and then as the picture gets clearer in the ICU, I can turn off the meds. I don't think there's any reason, if the patient is reasonably sick in the ED, not to give them the first dose of community-acquired pneumonia antibiotics, and we can certainly stop it up in the ICU.
Great. Additional thoughts regarding pneumonia, and you bring up a very important point there as well, Rory, with alternative diagnoses. And we're going to be seeing more and more patients with community spread who may in fact be COVID positive, but that's not what brought them to the ED per se, because it could be another process that's occurring in parallel. So we'll turn it over to another hot topic, which is steroids. So anyone want to share their thoughts about how we should be thinking about steroids now compared to how we were thinking about it 6 to 8 weeks ago?
So I can take the first swing at this because I'm pretty bullish on steroids. I feel like I always have been, and so I also think that steroids are the divider. Like, you either were a true believer or you weren't. And it's like every study that came out pre-COVID, you interpreted it the way it fit with your thought process. There was just enough like equipoise in all the studies that it would either confirmed what you thought or whatever way it was, whether you were steroids or not. But so I mean, again, out of the limited data that we have for COVID, so most of these are retrospective. There's a study by Fang that looked at COVID patients. Sort of did low dose methylpred, and the question on this one was, do you get delayed clearance from the virus itself? Because that was the whole reason why, from the first SARS and MERS data, that early recommendations were don't do this because it's going to delay clearance. So in this study, there's really no impact on steroids on virus clearance. Wang et al., they looked at admitted patients with COVID pneumonia. They were doing methylpred about 1 to 2 mg per kg per day for a week. And basically they had rapid improvement in oxygen and radiographic abnormalities. And they were weaned off oxygen earlier, 8 versus 14 days. And then Wu et al. Looked at basically another retrospective, about 200 patients with COVID. And, steroids were given to a sicker cohort, so there wasn't a huge mortality difference in that because of the cohort they were given to. But then when you look at the subgroup analysis, there really was reduced mortality with it. And then that sort of the other thing is sort of the surviving sepsis campaign as related to COVID. People with severe hypoxemia and COVID pneumonia, there's sort of this like weak recommendation to use steroids, because again, it's controversial. So like, it's low quality of evidence, weak recommendation, but it still exists in that surviving sepsis if that if that's the thing that makes you feel warm and fuzzy. I've switched. This is my new thing over the last week or two. Is I've switched to starting using methylpred on patients, and I do sort of the 1 mg per kg per day, but I divide it up into BID dosing. I think it doesn't want. You can do Decadron. I think there's data pre-COVID from sort of the ARDS data. You can use Decadron as well. I just use methylpred for ease, and I split up into that BID dosing. And to me, it also makes sense if you're saying this is a huge inflammatory process is driving this. From pathophysiology, there might be a role in steroids improving it. And I think it also makes sense on why TOSI doesn't have great data, because it really isn't, it's hyper focused on IL-6 as opposed to sort of this more broader inflammatory state. So that's my opinion on it. Like I said, this is pretty controversial. So
other thoughts, Janice, Manish?
Well, I'd love to hear Janice and Shane's thoughts on whether or not it should be administered in the ED.
I don't know a lot about steroids, but I would tend to say no in terms of the ER, but I'm happy to hear other people, what they think. I agree with Shane. I mean, I hadn't been using steroids. I used it for the first time on my last shift, just because, again, the whole try something new every week thing. I think I might put that into Monday's list of things to do. I don't really see a major downside. So, I mean, I think I'm gonna start it in the sick. Again, the ones with the everything's going bad, inflammatory state people. But I don't know that I think it's an ER thing. But I open that up to other opinions.
Well, and that's what I was saying earlier about the anticoagulation is, I kind of look at every intervention, especially when you're in a data light zone or a data free zone. And I try and weigh what's the risk benefit here. And I think that, that's very different from, anticoagulation risk versus steroid risks. And to me, I think the downside is sort of low, assuming you don't have a really obvious contraindication to giving someone, high dose systemic steroids. So I've switched to doing it, and I usually do it pretty early, but again, that's on people that are critically ill, which, in our ICUs they're usually showing me already on 100% 60 liters high flow nasal cannula. So I think, like, for me, a severe hypoxemic patient, I'm sort of getting them started as soon as I can. I think everything else, I don't know what to do with everything else, but that severe hypoxemic patient, because again, it's the same, Shanice, like, it's like, let's throw this Hail Mary, because what else are we gonna, what else do we have to offer? We don't have anything else. So in the risk benefit seems low to me. So I'm starting them early in the severe patients.
Great. And so we're gonna round it up, and I know Rory is trying to dial back in. Hopefully he'll be able to join us. And so go ahead. Oh, I thought that was, I heard something there. So what about emerging trends that we all need to be aware of? And so we'll just ask each of our panelists to if you have something, great. If not, no worries. We've covered a lot of emerging science as is. But anything that we should be thinking about as we're moving forward in the care of patients in this pandemic. So observations that you've had from the clinical environment, either the ED or the critical care setting.
John, I can maybe share a document that I'm working on for how best to use non-invasive in this patient population. This is still in draft format, but I think it's worth taking a look at. I think there's been a lot of kind of conversation on how best to use non-invasive. And so my hope is that this goes live within the next week or 2 weeks or something along those lines. But we kind of categorize non-invasive use into 4 buckets. And the first is pre-intubation, pre-oxygenation, kind of the idea that if you're intubating these folks, they're usually profoundly hypoxemic. And it's worth using non-invasive to try to get the PaO2 up as high as you can pre-intubation. The second is something I think Rory might have touched on, this idea that these folks, when they first come in, they've been hypoxemic for some period of time. They're usually coming in quite tachypnic, tachycardic. We've all seen these folks. And putting them on non-invasive for a brief period of time, a few hours, may allow them to decrease their work of breathing, kind of tip their supply-demand mismatch back into a favorable place. And allow them to de-escalate to something like a non-rebreather. So kind of this therapeutic challenge for a couple of hours. And then I think the most controversial amongst the committee that's working on this is this prolonged therapy, and that is keeping people on non-invasive for a longer period of time. And this is really an attending level decision. Interestingly, as we were talking about this on the last call, there are folks throughout the system that have very strong positive opinions of this. Folks that I believe the gentleman was from St. Mary's, other folks at Georgetown as well, that have cases where they've left people on non-invasive for several days and have then taken them off and discharged them home. So I think that this is something that we'll end up seeing more. And then the fourth bucket, not necessarily relevant to the ED, is post-extubation. But I think that we'll probably start to see this as something that's more universally accepted, or at least back in our armamentarium. You're muted, John.
Janice, Shane, any additional thoughts, emerging trends?
I have no other medication related things, but I will let you know hopefully next week how some of the playing around with different anticoagulants works out or doesn't. From a humanistic side of things, something that's really started helping me. So with all of our visitor restrictions, it's been very difficult for, I'm sure, all of us to have these people die and no family be around them. And something I started doing when possible is, this might be actually why I got COVID, but I pull out my cell phone and call the family in the room when the patient's dying and let them talk to the patient while they're dying. And it's actually been, I think it's helped the staff feel a little bit better. It's helped me personally feel a little bit better about the deaths. And so I just wanted to pass that on if you have any way of doing that, because I know a lot of us, when we're, you hope to be mediating life, but the rest of our job is to mediate death. And it's really hard to mediate death without talking to families and letting people, be there with the person they love. So that has been a helpful thing on the other side of this equation for me.
It's great. So true and very well stated, Janice. Shane, any parting thoughts?
Yeah, I mean, just to dovetail on that, Doximity has a pretty good app with a free video caller that works pretty well that, we've been using. I share that. I think that's the hardest part about this whole disease is, it's isolating for everyone, for patients, families, caregivers, providers. From my trends in that, I think I look more from an epidemiological trends. Is that, where you're going to start, again, we already mentioned this, start seeing the sort of sequelae of this sort of critical disease of people that recover from it. We're going to start seeing that more and more, avoiding anchoring, as Rory mentioned, because definitely sort of seeing the sort of everything's COVID, and that's kind of true, but there are things that are not COVID, and sort of just doing, our typical emergency and critical care stuff. And then sort of the last thing is, really sort of starting to think about more broadly, the likely resurgence we're going to see once this opens up. I've been sharing a infographic that I have from the course I teach that looks at the 1918 flu, and basically over a 16-month period, there are 3 very defined peaks that I think match exactly up with what we're going to see in COVID. There was a peak in February, March, another one in the late summer, and then another one sort of early winter, late fall. And I think that's what we're going to see, and sort of starting to think through how we navigate that with the lessons that we're learning from, this sort of first.
That's great. I think we lost you a little bit at the end there, Shane, but thanks so much for sharing. We'll go ahead and conclude now. I would like to thank all of our panelists and Rory, who's not on the call now, but is with us in spirit as we're finishing the call. And hope everyone has a great rest of the day, and really be safe, be cautious, and be well. These are our trying times for everyone, for our patients, for their families, and for all of us that are on the front lines as well. And so thank you to everyone for all that you're doing. We'll look forward to a pop-up session soon, and thanks again for joining us.